Hi learners, it's Em from Sononerds, and this video is on Unit 9, where we're going to talk about spleen anatomy, physiology, and the normal ultrasound appearance. So Unit 9, spleen anatomy, physiology, and ultrasound appearance. The spleen is an unpaired organ in the left upper quadrant. So this unit's going to cover the embryology, location, microanatomy, physiology, lab tests, and the ultrasound appearance of the spleen as it pertains to the sonographer. Section 9.1, Global Anatomy. Let's go ahead and begin with an overview of the spleen's location and surrounding anatomy. So the spleen begins to develop in week 5 and then finishes right about week 8. And the spleen is responsible for hematopoiesis. Hematopoiesis is the creation of blood cells. And the cells that carry out that function arise from the yolk sac, and then those are eventually going to differentiate into the distal aorta. And then the spleen cells actually also arise really close to the aorta and to other cells that differentiate into the cardiovascular system. So it's really not uncommon to see cardiac abnormalities when there are spleen abnormalities present as well. During the second trimester, the spleen is going to be responsible for both white and red blood cell production, and that lasts till about month 5. So in this image, we have a cross-section of the embryo. We can see the aorta developing back here. The spleen is going to differentiate from cells right in front of it. And so hopefully this location, this proximity of the spleen to other cardiovascular structures will remind you when we talk about other splenic anomalies that quite often cardiovascular anomalies are associated with it. Some other things that we can see in this image then too is the stomach. Remember, we kind of start as tubes. We have the liver in front of that, and then you can see kind of how all the peritoneal folds are kind of holding everything together. And this again reminds us too that the liver, stomach, and spleen are all peritoneal organs. And speaking of, the spleen is a peritoneal organ. So the spleen is covered by the peritoneum with just a little tiny part of it that's not covered right at the hilum. It's going to sit in the left upper quadrant in the left hypochondrium and sits beneath the 9th to 11th intercostal spaces. So here in the corner here, we have the spleen. It usually sits actually pretty far back into the body and rather lateral. It sits in between the 9th rib space and the 11th rib space, so up in that left upper quadrant in the left hypochondrium. And a lot of times we're going to use these rib spaces to help visualize the spleen during an ultrasound examination. As far as relational anatomy goes, the spleen is going to again sit posterior and lateral to the tail of the pancreas and the fundus of the stomach. It sits rather posterior to the splenic flexure of the colon. It's going to be lateral and superior to the left kidney, and it's going to be inferior and rests right against the diaphragm. So in this image here, we can kind of see where those organs sit. Again, the diaphragm is going to sit right along the superior border and actually wraps around posteriorly to the spleen. The stomach is going to sit on the visceral side, adjacent to quite a bit of the spleen. The left kidney sits in front of it, just kind of touching that hilum piece of it here. The pancreas tail, again, also kind of comes over, also sitting anterior to the spleen. And then we also have the colon, which will graze along the bottom or the inferior portion, sitting again also anterior. So the spleen really is one of the more posterior structures and one of the more lateral structures in the abdomen. Just like the liver, the spleen is held in place by ligaments made of the peritoneum. So we have the lienorenal ligament. That is going to be the ligament that connects the left kidney back to the spleen. Lino is the prefix for spleen. Sometimes you'll hear the splenic artery or the splenic vein called the lieno artery or the lieno vein. So the lienorenal ligament is going to hang out more towards the inferior portion of the spleen. At the superior portion, then we have the phrenosplenic. Phreno is going to refer to the diaphragm, and then splenic part is the spleen. So we have the phrenosplenic ligament that's going to attach more on the superior part, attaching the spleen to the diaphragm. Working down the sides, then we have the gastrosplenic ligament that's going to attach the greater curve of the stomach to the spleen, kind of at its mid-pole. We also have the splenocolic, which is again going to be kind of on the lateral anterior surface. That's going to connect the spleen to the colon. And then we also have the phrenicocholic ligament, which also attaches the colon to the diaphragm. And this is going to help to kind of cradle the spleen up in that left upper quadrant. So 5 major ligaments that we have that help hold the spleen in place. Next up, we have section 9.2, spleen anatomy. So the shape of the spleen can be variable, quite often though it's compared to kind of an ovoid shape, or like a half moon, or a crescent shape, or like an orange wedge. So it kind of comes to a point on the visceral side, and then it has a really wide base on the lateral posterior side. On the superior posterior surface, so that's superior, and on the back side of the spleen, this is the area that's going to be in contact with the diaphragm. And so it kind of takes on the shape of the diaphragm more in that convex orientation. When we come into the visceral side of the spleen, this is going to be a little bit more medial and a little bit more inferior on the spleen. This is going to have the concave portion. So this kind of dents into the spleen, then the backside kind of bows out. The visceral side is indented with a lot of the compressions with the organs that the visceral side comes in contact with. So we have the gastric impression, the renal impression, and then the colic impression. Remember, we also have the pancreas tail. That's going to rest more in this area here. We have the splenic artery and the splenic vein that both enter in through the hilum. So where those enter in on that concave surface, that is called the hilum, very similar to the kidney. That splenic hilum acts as an entry and an exit route for arteries and veins and the lymphatic vessels and nerves. And it again is kind of in that concave portion of the spleen. If the spleen becomes enlarged, which it is very prone to do, we call it splenomegaly. So if the spleen becomes enlarged, we kind of start to lose this concave part of it. And what we'll see is that the spleen becomes very round. The main arterial supply of the spleen is the splenic artery. So the splenic artery is the left branch of the celiac axis. So we have the aorta here, celiac axis. There is the gastric artery that comes off, goes to the stomach. We've got the hepatic artery that heads over to the liver. And that leftward branch is the splenic artery. And you can see here it's called the renal artery. So splenic artery travels anterior and superior to the pancreas. Little branches are going to come off, helping to bring oxygenated blood to the pancreas, and a few are going to travel to the stomach as well. But for the most part, it's really going to travel right into that hilum of the spleen. Once the artery gets to the hilum, what we're going to see is that the artery is going to branch, typically into 2 or 3 lobar arterial branches. And then those branches are going to course into the spleen and then start to branch smaller and smaller, very similar to how the kidney operates. Once inside, there's 2 to 4 lobular arterial branches, and then they just start getting smaller and smaller from there, branching into these very tiny trabecular arteries. The trabecular arteries are going to then, we're kind of getting to the microscopic piece at this point, they're going to branch into the white pulp and into the red pulp. Blood is going to get kind of filtered, more or less, through the spleen, and then the blood from there is going to go into the sinusoids. Sinusoids are going to start to converge together to form the veins. Those will be the trabecular veins. Those will start converging, and then we'll be back to our splenic vein. The splenic vein exits the hilum, and this time the splenic vein is going to travel posterior to the pancreas tail. So the splenic vein is actually one of our major landmarks to identify the pancreas tail, and that's because it runs posterior to it. It kind of wraps right around it. So we can see here that splenic vein is kind of poking out towards the head of the pancreas. What's special about the splenic vein is that as it travels more midline towards the liver, what's first going to come in is the IMV, or the inferior mesenteric vein. It then will join up with the superior mesenteric vein, or the SMV, and when they join together, that forms the portal confluence, which continues on to be the main portal vein and head to the liver. So what's significant about the splenic vein is that the splenic vein is bringing blood out of the spleen. This is blood that has been filtered, more or less, to get rid of all those red blood cells. In the spleen is where a lot of that hemolysis comes in, where the red blood cells are broken apart, and then the albumin picks it up and then brings it back to the liver for processing. Remember, that's the biliverdin, and then that gets put into the hepatocytes. Hepatocytes change it, and then it ends up leaving the body as bile. So the spleen being connected to the liver via the splenic vein and the portal system is super important. Here's just another example looking at those vessels. So again, we have the aorta. Celiac trunk or celiac axis is one of the first major branches. It has a little tiny branch off of it going to the stomach. That's the gastric. We have the hepatic artery, and then we have the splenic artery. That's the one we're interested in right now. Splenic artery has tiny little branches that go into the body and the tail of the pancreas. And you need to remember this is traveling on the anterior superior surface. It travels on top of the pancreas. Once it gets to the spleen, again, it's going to branch very quickly, and then it's going to travel into the spleen, going through the filtering process. Blood coming back out then is going to travel through those veins. They're going to confluence together to form the splenic vein. So that splenic vein, when it comes out, wraps around the pancreas tail, so posterior, deep into the body. We're going to have that splenic vein traveling behind the pancreas, joins up with the IMV, those continue over, joins up with the SMV, and then that's going to form the portal vein. So the splenic vein does not go back to the IVC, it joins up with the mesenteric veins to form the portal vein. Just like with all the other organs that we've talked about, the spleen is capable of also having its own splenic variants. The most common splenic variant is going to be something called the accessory spleen. And the accessory spleen is seen with a normal spleen. So that's there and present up in the left upper quadrant. And then what you're going to see is a little ball of tissue at the hilum. And that little ball of tissue is the accessory spleen. It's also known as the splenunculi. And these little balls of tissue are very benign. They're fed by a little vessel off of the splenic artery. They work just like the spleen does. This is typically a failure of parts of the spleen to fuse all the way together during development. So this typically ends up being an isolated finding with the spleen. And again, very common, little ball of tissue right by the hilum or maybe even a little bit towards the inferior portion of the spleen. Now this is different from polysplenia. Polysplenia is a bunch of tiny little spleens scattered throughout the body. So you can kind of have a main spleen with polysplenia, but then there's going to be hunks of splenic tissue scattered in different places, away from the hilum, away from the spleen itself. They can really be anywhere in the abdominal cavity. Now with polysplenia, these are associated with other abnormalities. You might see some pulmonary changes, some thoracic vascular changes, but as far as ultrasound goes, we can actually see biliary atresia. So that is the failure of the biliary tract to develop. We can see absence of gallbladder. We can also see gastrointestinal malrotation, and then we can also see some cardiovascular abnormalities as well. So polysplenia itself is actually a little bit harder to diagnose by just ultrasound. It's most likely going to be confirmed with CT imaging, but then we can kind of put those pieces together. If we're questioning polysplenia, they're missing their gallbladder, they have a history of cardiovascular things, then we can kind of start to put all those pieces together and suspect polysplenia. Asplenia then is kind of the opposite of polysplenia because A means without splenia, the spleen, so this is a condition where the spleen fails to develop. When the spleen doesn't develop, it's not the end of the world. It is not life-threatening with just the spleen being absent. The problem is that asplenia is even more associated with complex cardiac malformations. Remember, in the embryo, the spleen is developing from cells that are also going to differentiate into the heart cells, into the cardiovascular cells. And if that spleen doesn't develop, there might be a chance that a lot of those cardiac cells aren't developing either. And that's where we get some of our cardiac anomalies. And so with that, depending on how severe the cardiac malformations are, that could be more of the life-threatening piece of it. Polysplenia is associated with maybe a little bit more milder anomalies, where asplenia is going to lead into more of our complex cardiac malformations and other abnormalities of the body. Wandering spleen, then, also known as splenopetosis, means to have basically a droopy spleen. So petosis itself means falling, and you may have heard of petosis in relation to the eyelids, and we call those droopy eyelids our petosis, or the whole name is blepharopetosis. So petosis means to fall, and that's basically what happens to the spleen. Remember, we had all those ligaments helping the spleen to stay in place. Some of those ligaments fail to fuse with the peritoneum quite in the right way, or things can get kind of stretched out, and because of that then, the spleen just isn't held as nicely up in that left upper quadrant, so it starts to kind of fall down into the dependent portion of the abdomen. One of the first signs of splenopetosis is most likely the doctor being able to feel an abdominal mass. So they don't know that the spleen isn't where it's supposed to be underneath the ribs, and so if they're feeling around on the abdomen, they might feel like this extra hunk of thing, the spleen, hanging out a little bit lower than it should be. Those patients can go on to have abdominal pain, either from the spleen just being in the wrong position or something that we call volvus. And splenic volvus is also known as splenic torsion. Basically though, because that spleen is all loosey-goosey in the abdomen, it can flip on itself, twisting the renal artery and the renal vein. And when you twist those vessels, that can cut blood flow off through them. And if the artery is cut off, that'll lead to oxygenated blood not being able to get to the spleen, which will cause the spleen to die. Or if the vein is cut off, it means that blood can't get out of the spleen, which will cause the spleen to kind of get congested and back up with blood. Either way, painful for the patient. So if you're up in your left upper quadrant and you don't see a spleen up there, take a look around, see if you can identify a normal spleen somewhere else in the abdomen, typically a little bit lower on that left side. The last variant that might cause the spleen to not be in the left upper quadrant like we expect it to be is different displacements of the spleen. This is going to follow a little bit more of a logical pathophysiological path, in that if we have a mass in our abdomen, that mass, in theory, can push things around. So if we have a mass in the left upper quadrant, that might push the spleen a little bit more inferior. So if you have a large mass hanging off of the left lobe of the liver, that could push the spleen down towards the patient's hip. Similarly, if we have a left upper quadrant mass on the kidney or on the pancreas tail, that might actually push the spleen up a little bit higher than what we would expect up towards the thoracic cavity. We might also see the spleen kind of move up into the thoracic cavity if there's something wrong with the diaphragm, or if that lung deflates and loses volume, the spleen might kind of float up along with the diaphragm, kind of filling in that space that the lung would have taken up. And similar to masses being in the left upper quadrant, some thoracic masses can actually cause the spleen to become displaced as well. So if you are, again, scanning through that left upper quadrant, you're not quite seeing the spleen where you would expect it to be, take a look around, try to decide, is that wandering spleen, or is there something that is causing the spleen to be displaced from its normal location? Section 9.4, Splenic Microanatomy. As usual, we're going to take a look at the splenic microanatomy so we can learn a little bit more then about the physiology. To start, we're going to need to know that the spleen is covered in a capsule, and from that capsule are extensions of fibrous bands that kind of make this network or this webbing through the spleen. And that webbing or network is called trabeculae. So these are little extensions, little fibrous capsules that extend into the spleen, creating a framework for the spleen. And in between the trabeculae, where all those little gaps are, is going to be the functional part of the spleen, or the pulp. And there are two types of pulp found in the spleen. We have the white pulp and red pulp. So in this image here, we've got the splenic capsule. You can see how the trabeculae are kind of making this webbed network all through the spleen. They are an extension of the capsule into the splenic tissue. If we could zoom in on any one of these little gaps that are in between, this is where that red pulp and white pulp are going to be hanging out. So we are basically going to just zoom in a little bit on those and talk about white pulp and red pulp a little bit more in detail. So the white pulp of the spleen makes up about 25% of the spleen. So it's not the bulkier part. It is the less prominent part of the splenic tissue. And is again going to be spread out through the spleen in tiny little islands in the center of those gaps made by the splenic trabeculae. Within the white pulp, we are going to see what we call splenic nodules. These are going to be very similar to lymph nodes because the spleen itself is actually kind of just a big lymph node. So we're going to see little islands, little nodules of splenic tissue that resemble kind of lymph node tissue on the cell level. And inside the white pulp, we're going to see a really large number of lymphocytes, which are the white blood cells. And the white blood cells are responsible for fighting infection. So that's why this is called the white pulp. It is home to the white blood cells or the lymphocytes. There are 3 subsections of the white pulp, and they are each home to specific cell types that make up the lymphocytes. So here we have a diagram of a little piece of the white pulp, and we can talk about a few things in here. So we have the artery, and we have tiny little branches that come off of it. These are those end arteries. Normally, arteries connect to capillaries, those capillaries then connect to veins, and then the veins bring everything out of the organ. Well, end arteries are responsible for just bringing oxygenated blood in, and then that's kind of it. They don't really connect back to anything. So we see end arteries in the kidneys, we see end arteries in the liver. We have vessels that bring blood to an organ, don't necessarily connect directly to capillaries, but typically connect into a different system. So in the liver, the portal veins and the hepatic arteries connected together in the sinusoids, in the kidneys, the end arteries, or basically the afferent arteries. Those go in the glomerulus. The glomerulus went into the efferent arteries. So we kind of saw not a normal artery capillary vein connection there. And the same is going to be true for the spleen. Now, what's interesting about these ones is that these just kind of end in the red pulp. So the blood is just going to bloop right out the end of these. And then we're going to see in the red pulp what happens once the blood comes out. But again, going back to this white pulp, again, we've got those oxygenated blood cells coming in through the splenic arteries, and then they are going to interact with those 3 subsections of the white pulp. So the white pulp first consists of the periarteriolar lymphoid sheaths, which is abbreviated down to PALS. So the PALS layer is going to house or sheathe the arteries. So peri is by arteriolar arteries and sheaths. So you can think of this layer as wrapping around the arteries. The next layer then is the marginal zone. And the marginal zone is going to not only go around the PALS area, but it also goes around our follicles, or the splenic nodules that we see in the spleen. The splenic nodules then, which are also known as Malpighian corpuscles, these are going to be home to a whole bunch of white blood cells, little disease fighters that are going to help us out. And so that's what we see in each of these layers are white blood cells, lymphocytes that have very, very special jobs to do in regards to keeping our body healthy and getting rid of those foreign substances like viruses, cells, and debris. So in our PALS layer, this is the green layer here, what we most commonly see in here are T cells and macrophages. T cells are a specialized lymphocyte. Macrophages then are the cells that are going to go and eat all the things, so they kind of take things in and then process it so the body can get rid of it. The marginal zone is mostly just going to be macrophages. It does have a few B cells in it, but mostly just macrophages out in that marginal area. And then within the follicles, we have the B cells, which are going to be really responsible for a lot of our virus fighting, bacteria fighting, any sort of infection fighting is going to be kind of stemming from this area. So again, the white pulp is home to the lymphocytes, which are the white blood cells. 25% of the spleen is made up of the white pulp, and it is going to be the first area in which the blood travels through. The red pulp then is the rest of the spleen. So the red pulp makes up 75% of the spleen, and it gets its name red pulp because this is where a lot of those red blood cells end up as they leave the end arteries. When they make it out into the red pulp, they are going to interact with 2 very specific subsections. We have the venous sinuses and we have the Billroth cords. So in our picture here, again, we have a bigger artery coming in. We're going to have little arteries coming off, branching into the white pulp. The first layer is the PALS layer. Then we have the marginal layer around it. And then scattered throughout the white pulp are going to be our follicles or our Malpighian corpuscles. As blood comes into this area and it's carrying viruses or bacteria, all of the white blood cells are going to be activated and they're going to do their job trying to help the body fight infection. The other thing that we're going to see the spleen do then is dump those red blood cells into the red pulp. So now the red pulp is going to be home to a lot of the red blood cells, and within the red pulp we are going to see macrophages sitting out here in the Billroth cords. So the Billroth cords are the structures within the red pulp home to the macrophages. The other thing that we see out in the red pulp is something called venous sinuses. And these are really similar to the sinusoids that we see out in the liver. So these are going to be spaces for the red blood cells to enter in through. The sinusoids are all going to come together to form a vein, and those veins are going to continue to converge together to form the splenic vein as it leaves the spleen. The white pulp is the first area that the blood is going to interact with. It's going to leave the white pulp and enter into the red pulp. The red pulp's going to have its own interaction with it, and then all of that blood will eventually make it into the sinusoids, so then it can leave the spleen through the veins. As far as what to focus on for microanatomy, recognize the 7 things that are labeled in this image, and then know what goes into the red pulp and the white pulp, knowing that red pulp makes up most of it and the white pulp makes up the least amount of it. White pulp is home to lymphocytes. Red pulp is going to be home to red blood cells. So knowing that, we can now talk about section 9.5, the spleen physiology. I had mentioned before that the spleen is basically kind of like a big lymph node. So that is True, it is the largest lymphoid organ in the body. And really its purpose is to filter out the damaged cells, microorganisms, really any foreign materials that we don't want circulating in the blood anymore. And with the way that the blood travels through the white pulp, it actually is a very large participant in our immune system response as well. So again, once the blood enters in through the spleen, it's going to travel into the small arteries. And remember, the spleen has those special end arteries, which is going to play a really big role into how the spleen takes care of the body. So there are four main functions of the spleen. First one is destruction of red blood cells. Second is its immune response. Third is hematopoiesis. And fourth is storage. So let's take a look at these four functions a little bit more in detail. So one of the biggest things that we should know about the spleen is that it is responsible for the destruction of red blood cells. This is where a lot of its physiology purpose comes from. This is where a lot of the pathology is going to pop up with it. So this idea is very important. So the destruction of the red blood cells is going to occur out in the red pulp. And it's going to happen as the blood cells move out of the arteries and out of the end artery especially. As the red blood cells enter into the red pulp, they're going to kind of float out there for a little bit, moving their way toward the venous sinuses. So let's take a look at this diagram to see how the spleen takes care of the destruction of red blood cells. So in this example here, we have three different red blood cells coming in through the artery, and they're going to head out through an end artery. We've got just a normal healthy red blood cell. We've got kind of a sick red blood cell, a little misshapen, probably quite a bit older. And then we have a red blood cell that's got a little something extra going on. That's probably changing how this red blood cell is functioning. And so we want to take care of that and heal that red blood cell. So these three red blood cells are going to end up in the red pulp. Now, let's start with the normal red blood cell. That one's going to head out. It's going to get to what we call a fenestration. So the fenestrations in the sinus are just slits within the venous sinus. It's going to get up to one of those. It's going to squeeze right on through. It's going to head back to the vein and then head back to the body. Normal, healthy red blood cells make it through the spleen, no problem. They squeeze right through and off they go. What's important is that the spleen takes care of those damaged or sick red blood cells or the red blood cells that need a little help. And it's going to do that through a process called pitting and culling. So let's first talk about the red blood cell that has a little funky thing in it. So that blood cell is going to come through out the end artery and end up in the red pulp. That little red blood cell is again going to travel towards the sinus. And as it squeezes through the sinus, what ends up happening is that unwanted piece of it is going to pop out. And so that is the pitting. These fenestrations are not going to allow that abnormal piece to move through it because they are probably the wrong size or the wrong shape for it. And so it ends up almost looking like there's just this little bite out of the red blood cell. And that's still okay. That red blood cell will survive, makes it through without its little buddy, and then goes into the blood system just like the healthy one. What ends up happening though is that little foreign substance that is out there might be abnormal DNA, abnormal hemoglobin. Those are going to hang out in the red pulp, and a macrophage is going to come on up, find it, and eat it. So it's really going to take care of that foreign material. The other thing that we see then are when blood cells get old or there are some blood diseases that cause the red blood cells not to be the normal healthy shape. Those are going to come out, head to the red pulp, and they're going to try to get through the fenestrations or those little slits, and it can't make it. So this is the culling piece of it. They can't make it through. Then you get stuck out in the red pulp. Another macrophage is going to come by, eat it or destroy it, which is the lysis part. Going to break up that red blood cell. Remember that breaks it into like iron and heme. That gets broken into the biliverdin and all of that. And so at some point, albumin's going to come through, grab those little pieces, make it through the fenestrations, and head off to the liver as well. So the macrophages are going to take care of the sick blood cells that have been culled out of the blood, hanging out in the red pulp. And then they're also going to take care of the pitted piece that hangs out in the red pulp as well. So macrophages have a lot of work to do out in that red pulp, helping the body to break down those pieces that we don't want anymore. The fenestrations then allow for healthy, normal red blood cells to move through very freely so they can continue circulating throughout the body. So pitting and culling is how the spleen helps to either destroy red blood cells or heal them so they can continue circulating. It's important to note too that not only are red blood cells coming out through this artery, viruses, bacteria, all that kind of stuff is also traveling through your blood. And when it gets to the spleen, it can't fit through the fenestrations either. So not only has it activated your immune response because it went through the white pulp, it's now stuck out in the red pulp where the macrophages are going to come up and also help to destroy those viruses and pathogens that are hanging out there. Now the second job of the spleen we've mentioned is the immune response. And you don't need to memorize any of this. This is a whole lot of information that is really well beyond the scope of the sonographer. I think the biggest part about the immune response piece of it is that when that blood travels in through that white pulp, there's kind of this cascade that starts to happen when there's viruses or bacteria that the body needs to take care of. So it first comes in, it's going to interact with the T cells that were hanging out in the PALS portion, that periarteriolar sheath. Hangs out with the T cells. T cells are like, whoa, somebody's in here, we don't want that. T cells go and tell the B cells in the follicle and be like, hey, we got some dudes in here, we don't want them. So then the B cells are going to recognize these and become responsible for making antibodies. Those antibodies then are released. Antibodies go and find the viruses, find the bacteria, kind of glob onto those bad actors, making them basically useless. So T cells sound the alarm, B cells make the antibodies, and then the macrophages are just hanging out, waiting for dinner, so they can get rid of the bacteria and the viruses and all of that stuff. So immune response, just know that it's due to the white pulp and all of those white blood cells that are hanging out in the white pulp. That chain reaction is what's going to help us stay healthy. The third function of the spleen then is hematopoiesis. Remember that hematopoiesis means the creation of red blood cells. So with the creation of red blood cells, that is the spleen's main job during fetal development. And that's really going to only last until about the 5th month of gestation. After the 5th month, the bones are going to start to take over, that bone marrow. And that's typically where our red blood cells, white blood cells are all made, is within our bone marrow. The spleen can take over again if there's really super severe anemia in an adult patient. Anemia means low red blood cell count. So if the bone marrow is not making enough red blood cells, then the spleen can start to help out with it. But it's got to be pretty bad before the spleen will kick in. It's within the red pulp that those hematopoietic cells hang out. So that is where they will be activated, making those cells to circulate into the body. And then the last function of the spleen is storage. So remember when we learned about the liver, we talked about how the liver holds a really kind of high percentage, as far as organs go, a very high percentage of the blood volume. And if we were to start hemorrhaging, the liver can recognize that, kind of squeeze all the blood out of the sinusoids and try to keep up the blood volume. Well, the same thing happens in the venous sinuses of the spleen as well. They can hold on to a lot of blood. The problem is that sometimes there are blood diseases that cause blood to kind of back up in the spleen. It could be that the liver is not accepting blood from the portal splenic system, or there's just a lot of blood cells that are ending up in the red pulp that need to be pitted and culled because of their deformation. So there's actually a lot of blood diseases that can cause the spleen just kind of be overworked, holds on to too much blood, and then it starts to become enlarged. And when we have a large spleen, we call that splenomegaly. The other thing that the spleen is responsible for storing are platelets. So sequestering means to store, so it sequesters the platelets in the spleen, which are also known as thrombocytes. And the thrombocytes are basically there to help clot off any sort of open wounds within the body. So the thrombocytes hang out in the spleen, and as the body recognizes that there might be a wound somewhere, it will release those platelets so they can do their job. But it just kind of manages how many platelets should be circulating in the body. There are some splenic diseases that'll cause the spleen not to be very good at that, so it puts way too many platelets out, or it takes too many platelets back in, causing the blood to be very thin and not coagulate very well on its own. So storage, hematopoiesis, immune response, and destruction of red blood cells are the 4 main functions. I would focus on knowing what pitting and culling is, generally why the spleen is part of our immune response system, that hematopoiesis really is only an embryological function unless somebody is very ill, and that storage of blood can lead to splenomegaly, or some other diseases that are blood and spleen related. In your workbook, I did leave a couple links for some videos that I really liked. If you have not heard of the Crash Course system, it is absolutely amazing. And they have an excellent pair of videos that go over the immune system if you're interested in learning a little bit more about the immune system and then how the spleen plays a role in it. Otherwise, another really good video for a review of all the spleen physiology is also linked in the workbook. It goes over the anatomy of the spleen, the microanatomy, and then the physiology as well. A little bit more detail than what we need for sonographers, but it's nicely done with drawings and explanations. To finish up the spleen physiology then, we are going to talk a little bit about some lab tests that go along with the spleen. That'll be in section 9.6, spleen chemistry. There really aren't any splenic lab tests that are very specific to the spleen. Really what we want to know about the spleen and the rest of the body is what's going on with the blood cells. So we can do that through a CBC, which is known as a complete blood count. And the complete blood count is actually going to be very relevant to the spleen because we're talking about red blood cells, we're talking about white blood cells, and we're talking about platelets, all things that the spleen has a role in. So kind of understanding the basics of a CBC panel is actually pretty helpful for the sonographer just to kind of get a feeling for where the body's at. Almost everyone gets a CBC panel done. It's a very common blood test. So if you can kind of pick out some of the key factors from that blood test, it can kind of help you to better diagnose your patient through your images. There are tons of things that the CBC test can test for. They are very specific to the red blood cells, the white blood cells, and the platelets. So as far as red blood cells go, some of the very common ones are the red blood cell count. So we're literally just looking at a smear of blood and counting how many red blood cells are in it. You want enough so you have enough oxygen and blood cells circulating your body. Hemoglobin is another kind of way to take a look at how many red blood cells are circulating. Hemoglobin is the oxygen carrying part of the blood. And so if you have enough hemoglobin, then you most likely have enough red blood cells. An important test from the red blood cell portion is the hematocrit. Now the hematocrit is going to measure the percentage of your total blood volume that consists of red blood cells. In a patient who is internally bleeding, they are going to have low hematocrit. So hematocrit ends up being a very important test to understand, is there internal bleeding or something that we really should be concerned about, especially if that hematocrit gets too low. There are some other red blood cell tests that are going to include the lab technician looking for shapes of the red blood cells and the age of them as well. White blood cells then can also be evaluated in the CBC. Just like the red blood cells, we can count the white blood cells. We want to know, is there enough white blood cells? Are there too many, like we would see with an infection? Are there too little, like we would see with some cancers? If on general inspection that we see that the white blood cell count is excessively high or excessively low, and maybe just in general this might happen as well, they can do a white blood cell differential, where they're going to look a little bit closer at the different types of white blood cell counts, and then kind of count those out, and then give percentages of them based on which are more prominent in the count. That might help clinicians to diagnose a little bit further what's going on with the body. Evaluating the platelets is also part of the CBC. Just like the other ones, we're going to count how many platelets are circulating in the body. Are there enough of them? Are there too many of them? That's the question. We can also take a look at the size and the uniformity of the platelets through a couple other tests as well. By no means as a sonographer do you need to memorize all of these and know exactly what they all mean, but it's good to know that red blood cells are oxygen carrying cells. The white blood cells usually have to do with infection or cancer, and the platelets tell us how well we can stop bleeding or not stop bleeding. And so with those three ideas in mind, we have names then for increased red blood cells and decreased red blood cells, increased white blood cells, decreased white blood cells, increased platelets, and decreased platelets. So these are probably the 6 things that I would focus on as a sonographer that are actually going to be helpful for you in your studies and in performing exams, taking care of patients. And it's going to be super helpful if you can break down all of these terms into their medical prefixes and suffixes. So let's start with the red blood cells. Increased red blood cells is polycythemia. Poly means many. Cythemia means related to blood cells, so many blood cells. Decreased red blood cells then is anemia. A is without, anemia again referring to blood cells, so without blood cells. So if a person has too many red blood cells or maybe has like higher oxygen requirements, then we are going to see polycythemia being involved. We can also see some splenic diseases. There's one called polycythemia vera that is going to be a splenic disease that causes the blood to become very thick. Opposite of that then is decreased red blood cells. We might see that the body is destroying those red blood cells quicker than it can make it, and therefore we're going to see anemia with that. Anemia is probably one of the more common things that you've probably heard. Females tend to become anemic during menstruation because they are losing blood quicker than they are actually making it. Anemia can come along with low iron levels as well. So anemia is probably going to be one of those easier ones for you to remember, knowing that it is low red blood cells. Switching over then to the white blood cells, increased white blood cells is going to be leukocytosis. Leuko referring to the white blood cells, cytosis meaning in regards to cells. So leukocytosis is the increased white blood cells. Increased white blood cells are typically common with infection. That's a big one for sonographers. So you really need to commit to memory on this one. Leukocytosis means too many white blood cells typically associated with infection. Opposite of that, then we have decreased white blood cell count, and that is called leukopenia. Leuko again referring to the white blood cells, penia meaning deficient in. So leukopenia means that we don't have enough white blood cells, and that is going to be more common in people who have autoimmune disorders or possibly cancers of the immune system, like of the lymph nodes. Lastly then, if we take a look at the counts on the platelets, if we have too many platelets, that's called thrombocytosis. Thrombo referring to the platelet, cytosis again, cell-related, so thrombocytosis is too many platelets. Thrombocytosis is common in solid organ cancers. Those cancers tend to cause the body to make too many platelets. Those platelets then kind of get held together, and it makes our cancer patients more susceptible to developing thrombosis throughout the body. Opposite of that then, we have low platelets, which is known as thrombocytopenia. Same idea, thrombo referring to platelets, cytopenia referring to a deficiency in cells. So deficiency in the platelets or thrombocytopenia could be associated with the spleen storing too many platelets, or blood cancers like lymphoma or leukemia, or possibly we'll even see it with other infections. So these are very key terms related to the complete blood cell count. These are really going to help you to kind of get a baseline, to get some ideas as to what you're going to look for in your ultrasound examinations. This chart then, I will not be reading to you. You can take a look through it. It's in your workbook. Anything that's highlighted in purple are more likely to be related to the spleen, which is why I have them highlighted that way. This is just really kind of a reference more than anything. You do not need to memorize it. I would refer back to your 6 key terms and kind of keep in mind what might cause any of those 6 terms to occur, but this also highlights it here for us nicely. All right, now that we know about all the anatomy and all the physiology, we are ready to take a look at the spleen by ultrasound. Here we have a few examples of very normal appearing spleens. These are all taken in the longitudinal plane, typically from the left coronal approach. So we're going to find a space in the 9th, 10th, or 11th ribs. We're going to place our transducer along with those ribs so we can elongate the spleen. Letting the patient take normal respirations in and out, we're most likely going to be able to see that spleen nicely using that window, just kind of waiting for the spleen to come in and out. Once you identify where the spleen is, though, you will be able to see a very homogeneous, kind of medium to low level gray structure. It's going to have very smooth borders, and it's going to have kind of an echogenic capsule surrounding it. When we compare the spleen's echogenicity to the liver, we'll find that it's relatively isoechoic to maybe just a little bit more hyperechoic than the liver. Especially if we go back to our kids love soda pop, we've got liver and then spleen, then pancreas. So it sits probably closer to the liver echogenicity than pancreas, but it can appear a little bit brighter. So let's take a little bit closer look at these images. We'll start up in this top one here. This is all the splenic tissue surrounded by kind of a thin echogenic capsule. On this side here, we have the diaphragm. So this is our superior border. This is our lateral border over here, the inferior border, and the medial border. This happens to be the hilum in the longitudinal plane. Looking at this picture here then, again, we've got kind of an echogenic capsule surrounding. This is all diaphragm right here, this thicker, bright echogenic structure, very similar to how it appears over the liver. Superior to that then, we have the left pleural space. So we want to make sure that we're looking in the space for fluid in the abdomen or fluid on the left side of the thorax. We can see that it is adjacent to the kidney. This is another great way to kind of evaluate the exogenicity of the spleen and the kidney. You want your spleen to be brighter than your kidney parenchyma. Here's another image of the spleen, being able to see all the way down to the inferior tip of the spleen to the superior tip. Again, nice image of the diaphragm through here, showing just a very nice homogeneous structure. This is another view of the spleen, kind of sliding down. Again, spleens can take on a wide array of appearances. We're just looking for that kind of low-level gray, concave, convex structure up in that left upper quadrant. Note again that we are coming from a left coronal approach, so usually you'll have your patient rolled up towards you, again fitting that transducer into those rib spaces to be able to see the spleen. I do want to point out that one thing that I've noticed in my years of scanning the spleen is that a lot of times, like you can see it in this one here, this is lung kind of sitting on top of the spleen. And so when you already have lung sitting on your spleen, if you were to have this patient take a deep breath in to hold it to see if you can get a better window, this lung is going to expand and actually cover up more of the spleen than you'd probably want. So one of the tricks that I have for imaging the spleen is to kind of get in the right position, wait for the breath to bring the spleen in and out. You typically can see it best on an exhale. So it might actually be beneficial to have the patient take a breath in and then exhale completely. See if they can deflate that lung as much as possible, and then you might be able to see more of that superior border. So long spleen, you're looking for border to border. You'll often see the kidney sitting just medial to it. I always kind of joke around with students too, when you can't find your long kidney, try to find your long spleen. You'll find your long kidney no problem. When you can't find your long spleen, find your long kidney, angle up, and you'll be right there. So use your windows, use your landmarks, use what you know about the left upper quadrant, and then you'll be able to help yourself kind of find the spleen and lung or find the kidney and lung. Here are some examples then of transverse spleen. This one holds a little bit more controversy in the way that we image the transverse spleen. So I am going to teach you the way that I believe is correct, because it is the way that we image just about every other organ in the body. Once we have a longitudinal picture of an organ, we turn the transducer 90 degrees. By turning the transducer 90 degrees, we have entered into that transverse plane on the organ, and now we can take our transverse pictures and measurements. So remember when we were looking at our long spleen, we have that transducer fitting nicely in between the rib spaces. You typically don't have rib shadow on your long picture. When you switch to the transverse, you are now going to be cutting across ribs. And so it is not uncommon to see ribs in your pictures. You'll have those rib shadows coming down. Take a picture here, slide to a different set so you can see what is behind those shadows. It's okay to take multiple pictures of the spleen when you need to. Now the controversial part that comes in with this is that quite often a lot of sonographers have been taught or just kind of fall into it. When they do their 90-degree rotation, they start to almost rotate all the way into 180 degrees. And so what basically happens is that they get a backwards long picture. And that's not quite what we want for our transverse image. They look very similar, which is why I think a lot of sonographers kind of end up rotating into that 180 degrees. So my best advice to you, find your long, 90 degrees to it is your transverse. You'll most likely have some rib shadows over it. Now, of course, if you're taught by somebody who believes in the 180 degrees, don't argue with them. Go ahead and just do it. Know, though, that you should take a look through this plane as well. Another thing that I like to kind of point out, that is if you're in that transverse spleen and you sweep down towards the left kidney, you're most likely also going to see a transverse kidney, because they do kind of sit in the same orientation. So if you are not sure that you are all the way in a transverse spleen, sweep down. It's not 100% effective, but for most people, I would say your transverse spleen matches up with a transverse kidney inferior to it. As far as measurements go of the spleen, there's really only one that we are actually super interested in, and that is our long measurement. Your spleen should not measure more than 13 centimeters from inferior pole to superior pole. So in the long axis, normal spleens measure less than 13 centimeters. I just want to highlight that there is some material out there that mentions that 12 centimeters is the upper limit of normal for the long axis measurement. Your boards are not going to ask you which of these is normal, 12, 12.5, or 13. They are most likely going to be 5 centimeters, 1.73 millimeters, 17 centimeters, or 12 centimeters, or 11 centimeters, and you need to pick out the one that's the normal size. And you're going to be responsible for picking out the normal size one or recognizing the one that's out of normal limits, making it splenomegaly. So even though 12 centimeters is considered abnormal by some literature, 13 centimeters is definitely abnormal by all literature. The other ways that we can measure the spleen would be in AP diameter, when we have the anterior-posterior dimensions visible to us by taking that left coronal view. We can also measure the width of the spleen either in longitudinal or also in transverse. Total splenic volume then, if we multiply those together, we do get 60 to 200 milliliters. Knowing the volume of the spleen is going to be helpful for determining if a person truly has splenomegaly versus they're just, a 6'8" person with a 14 centimeter spleen, and that's just normal for them because they are a tall person. It's not uncommon to see tall, skinny organs in tall, skinny people. So if the volume doesn't indicate that there's splenomegaly going on, then the 14 centimeters might actually be very normal for that person. Lots of numbers and measurements on this graph. The big one again is going to be knowing that the normal spleen can measure up to 13 centimeters. On the bottom here, I do have a couple examples then of how those measurements are taken. Remember, these pictures are diagrammed out as the spleen sits in the body, not as they sit in our picture. And I'll show you an example here in a second here. But we measure length from superior to inferior pole. Width is going to be then from hilum to lateral. Depth then we usually see in our axial plane or in our transverse plane, because that is the plane that shows us anterior to posterior when we are coming from a left coronal approach. And the orientation of the spleen can get a little tricky for new sonographers. So remember, wherever our transducer is touching, that is the top of our picture. More often than not, we are kind of oblique in those rib spaces when we are getting our long spleen images. So this is left lateral, and it's actually a little twisted, a little oblique. So this is our left lateral side. This is going to be our superior side, kind of pointed towards the patient's back. So this is like superior, almost wrapping around a little bit to posterior, but mostly in the superior plane. So then we have our opposites. We have left lateral into medial, which makes sense. The kidney is medial to the spleen. The hilum is medial on the spleen. And then we have inferior opposite, again, making sense because the kidney is inferior to the spleen. So we are shooting across the abdomen in a coronal view, left lateral to medial, superior to inferior in our longitudinal picture. This is where you're going to take your measurements of your spleen. You're going to find the inferior pole, and you're going to measure back to the diaphragm. Knowing that the spleen can take on a lot of different shapes, it's going to be important for you to practice measuring and looking at the spleen. One of the biggest things for measuring the spleen is going to be identifying the inferior pole and then not measuring outside of the spleen when you measure. So for example, this one's pretty straightforward. You can put your caliper here, basically just follow the hilum or the border of the spleen, go back to the diaphragm. That's going to be a very clear, straight cut measurement. What about this one though? If this is our diaphragm back here and this is our inferior pole, we could go here to here, but we have measured way outside of the spleen at this point. So we'd actually want to come back here, again, follow that medial border going back to the diaphragm. Same idea with this one, find your inferior pole. If we wanted to just connect to the diaphragm, we could cut across like this, no problem, but that's not how you want to measure. You want to measure in the spleen. A little bit out is okay, but really, for the most part, your measurement should be in the spleen. So, caliper is placed on the inferior pole, eyeball it back, just barely cutting across to the diaphragm. When we need a transverse picture then of the spleen, again, I teach it that we rotate 90 degrees. So we have gone from in between rib spaces to now cutting across the ribs. We are going to have rib shadows in our transverse images. When we do that, we're still on the left side of the body, on that left flank, so we still are in contact with the left lateral side of the body, showing the left lateral side of the spleen. Now remember, we are kind of oblique for our long, which means we're kind of oblique for our transverse too, because we have gone 90 degrees. So these are rotated just a little bit again, but now we've got left lateral to medial, because we're going to go opposite. And then we have anterior to posterior. So that notch is facing towards the patient's front. And so we see that anterior to posterior dimension. This is the hilum in transverse. Makes sense, it's on our medial portion. And again, remember, we're skewed a little bit here because we're a little oblique on that flank position. So it's not uncommon for people to get kind of confused about how the spleen is actually oriented in there, because you've got the patient rolled and you're coming from a coronal view on both of these. Just remember, you're always in contact with your left lateral. That's opposite's always going to be medial. When we're in long, we can see superior because we can see the diaphragm to inferior. Again, we're going to do our long measurements here. So this would be long measurement. This would be our width measurement. We're measuring hilum out to the back of the spleen. In transverse then, this is our AP dimension because now we're anterior to posterior. And we could do another width measurement from lateral to medial. If this was the image that you originally get when you rotate your transducer into 90 degrees into the transverse, I would maybe have the patient take a little breath in. Their normal respirations might bring the spleen parenchyma out of that rib shadow. You'll just take another picture showing the areas that you couldn't see in this one. It may be possible to avoid rib shadows completely if you come into a subcostal point of view, but quite often that spleen is just way too lateral, way too high up in the abdomen. It doesn't always work. So more often than not, you're going to be intercostal looking at the spleen. Out of all the variants that we talked about, displacement of the spleen and wandering spleen or splenoptosis really just involve the spleen being in an area that it shouldn't have been in. Asplenia is going to be a spleen that doesn't exist. Polysplenia is pretty difficult to diagnose by ultrasound, but accessory spleens or spleneculi are actually very easy to diagnose by ultrasound. So in these images, we have a few different examples of those accessory spleens. Again, this is our splenic tissue. This is just a little round ball, same echo texture. If you were to put color on, you might be able to get a little blood vessel coming off of the splenic artery into this area. So we typically see them near the inferior border, or as this one is demonstrated, this one's at the hilum. This is the hilum right here. So we are seeing that accessory spleen. You can have more than one. So again, here's the hilum, one spleneculi here, another one here, another example, two little accessory spleens hanging out by the hilum. So this is a very common finding, documented if you see it. Last up then we have section 9.8, the protocol. Now the protocol for the spleen is actually really quick and easy. There isn't a whole lot to image with the spleen, and there isn't a whole lot of pathology that pops up in the spleen either. When an abdomen complete is ordered, the spleen is usually going to be part of that. The patient might just have abdomen pain. They're going to look at the spleen because it's part of the order. There are times that the doctor might be feeling around and think, hey, that spleen looks kind of large. Let's get an abdomen ultrasound. So now you're looking at the liver, because the liver and the spleen are connected. There might be some sort of pathology going on between the two. And then you're going to take measurements, kind of evaluating how large that spleen is. So it's very common for the spleen just to be included in the other exams when you're doing an abdomen complete. However, once the doctor diagnoses splenomegaly or an enlarged spleen, or the patient maybe had a recent infection like mono, it's not uncommon for them just to come in for a quick spleen exam. All they want is a measurement of the spleen and then you're done. So those left upper quadrant limited exams are usually very quick. You just take a few pictures of the spleen and lung, a few in trans, and do your 3 measurements. When the spleen is part of an abdomen complete, we usually only do the 1 measurement in longitudinal, unless we find that that is abnormal, being over 13 centimeters, then we'll add in some more pictures on top of it. As far as patient prep goes, there really isn't anything that they can prep for just for the spleen. If the exam is part of an abdomen complete, the patient will be NPO. If the exam has been ordered just to look at the spleen for measurements, you typically do not need any sort of preparation. Your low frequency curvilinear transducers are going to be your best bet, so somewhere in the 5 to 1 megahertz range for adults. As far as protocol goes, it kind of depends on why you're imaging the spleen in the first place. Is it just part of another exam? Then we're going to take a long spleen and a measurement and a trans spleen. If we are just taking pictures of the spleen because maybe we're following up spleen pathology seen from like a CT, maybe we know the patient has splenomegaly, probably going to take a few pictures in long, a few pictures in trans, and then again, we're going to get those 3 measurements on top of it. But again, in general, regardless if it's standalone or part of another exam, a couple long pictures, trans picture, and you're typically done with your spleen protocol. And that brings us to the end of our spleen anatomy, physiology, and ultrasound appearance lecture. You do have some activities in your workbook that you can work through, and then those open-ended questions that you can quiz yourself on the content presented.